All right, let's jump right into this explainer. If you're a radiation oncology resident, you already know that managing late toxicities is honestly just as important as the primary treatment itself. Today, we're unpacking a highly technical but totally game-changing procedure, preserving fertility during total body irradiation using helical tomotherapy. We're going to walk through the exact step-by-step clinical workflow from a recent technical report that's literally changing how we protect our younger patients.
So picture this. It's a scenario you're definitely going to see in clinic. You've got two young adult patients, a 20-year-old guy and a 32-year-old woman. Both are battling severe sickle cell disease, and both need allogenic stem cell transplants. Here is the massive clinical challenge. How in the world do we deliver a 3-gray conditioning TBI regimen to their entire body without completely wrecking their reproductive futures? Remember, they're undergoing this for benign indications. That means their life after the transplant, like their ability to have a family, is absolutely paramount. Now, the stakes here, they're grounded in some hard radiobiology, stuff you absolutely need to know cold for your boards and your practice. The legal dose for 50% of human oocytes, the LD50, is actually less than 2 gray. And for the guys, a single dose of 2 to 3 gray can trigger temporary azoospermia, and hitting 4 gray can delay sperm recovery for up to 5 years. So our margin for error here is essentially 0. Precision isn't just nice to have, it is absolutely critical if we're going to save their fertility. Here's our quick roadmap for today's explainer. We'll cover the fertility challenge, compare standard methods to HT-TBI, break down the simulation and contouring, dive into the planning mechanics, and finally, look at the actual dosimetry and in vivo results.
Okay, part 1, the fertility challenge and setting our clinical context.
Moving right along to part 2, standard linear accelerator techniques versus helical tomotherapy. You might be wondering, why do standard linear accelerator techniques fall so incredibly short when we're trying to spare the gonads in full-grown adults? Well, if you've ever wrestled with those massive custom compensators in the clinic, you know exactly what I mean. Traditional approaches rely on these huge extended source-to-skin distances, Surabent blocks, beam spoilers. It's a whole ordeal. It's wildly uncomfortable for the patient and a pain for the staff. But here's the real kicker. If you try to use a standard clamshell lid shield for the testicles, you can actually increase the local dose because of electron scatter. Yikes, right? Helical tomotherapy, though. It uses this incredibly elegant radial dose delivery. You get amazing conformity and homogeneity with built-in image guidance, and you can totally ditch those heavy, clunky modifiers. All right, part 3. This is the real meat of it, simulation and volume delineation, the exact how-to. This right here is the stuff you'll use in your daily practice. How do we actually set up the simulation and draw the precise margins needed? First, the patient is supine in a vacuum cushion with a custom thermoplastic mask. But here's the major catch. Because the helical tomo unit maxes out at a 160 centimeter field length, you literally cannot scan a full-grown adult in one go. You have to do a dual scan CT. You scan head first down to the mid-femur, and then you flip them feet first for the legs. And you absolutely must use a radiographically opaque wire to mark your match line at the mid-femur. Why there? Because that keeps the match line completely out of the way of the genitals, avoiding any scary dosimetric hotspots. Next up is contouring. And as a resident, I know you're spending a ton of time doing this. These OAR margins are prime testable material. The brain gets a 1 centimeter contraction. Kidneys? Unchanged. But listen to this. The lungs and heart are contracted by 1 centimeter. Why? To account for normal breathing motions so the ribcage actually stays inside the target volume. Now for the avoidance structures. The testicles get a nice, generous 5 centimeter expansion. The ovaries, though, are way trickier. They only get expanded by 0.5 centimeters and then contracted out of the bony pelvis plus 1 centimeter. And this leads us to some really brilliant Boolean logic to build your planning target volume, or PTV. Your clinical target volume is just the whole body minus the avoidance structures, right? Then you expand that CTV by 1 centimeter and subtract those avoidance structures out one more time. This little logic trick guarantees a razor-thin dose gradient right at the edge of the gonads. We're talking maximum protection without sacrificing the marrow treatment. Visually, check out this 5 centimeter expansion ring around the testicles for our 20-year-old male patient. Because of external anatomy, we essentially have the luxury of space. We can push that high-dose region far away to make totally sure the area is spared. But contrast that with our 32-year-old female patient. The internal anatomy of the pelvis is incredibly cramped. You're working with just a 0.5 centimeter expansion around the ovaries.
It is a wildly demanding dosimetric challenge to carve that dose out of the pelvis without accidentally underdosing the pelvic bone marrow right next to it. And honestly, that's exactly why helical tomotherapy is the perfect tool for the job.
Okay, part 4. Let's get into the treatment planning mechanics and optimization details.
Once your attending approves your contours, you're going to sit down with your dosimetrist and get into the physics of the plan. You'll be verifying some very specific machine parameters. We're prescribing 3 gray to 96% of the PTV. With a 5 centimeter field width, you're going to push for the lowest modulation factor, in this case it was 2, and the loosest pitch, around 0.303 to 0.330, that still hits your strict constraints. Expect to run, 15 to 20 optimizations. It's going to take about 45 to 60 minutes of planning time. And because this is such a complex, highly modulated dual scan delivery, rigorous QA is non-negotiable. I know QA can sometimes induce a bit of anxiety, but it is absolutely vital here. You'll use a 3D diode array cylindrical phantom, like the Delta 4, and run both the head first and feet first plans. Your gamma passing rate criteria, that's 3% dose difference and 3 millimeters distance to agreement, needs to be strictly above 90% for safety.
Fast forward to treatment day. Image guidance is everything here. Setup relies on 4 coarse, megavoltage CT scans covering the head, thorax, pelvis, and feet. You run an autofusion to the planning KVCT, and then you, the physician, must manually verify those axial, coronal, and sagittal images to lock the coordinates in perfectly. This vital prep step takes about 15 to 20 minutes before you can even think about hitting beam on.
Finally, part 5. Dosimetry and our real-world in vivo results.
Let's look at the actual numbers to see if all this hard work pays off for your patients. Check out the planned dosimetry. The median planned dose to the testes was held to a crazy low 0.35 gray, and the ovaries, just 0.86 gray. Remember our radiobiology limits from earlier? We are easily clearing those 2 to 4 gray danger zones. We are effectively shielding their reproductive futures while still fully delivering the 3 gray conditioning dose.
These isodose color washes just beautifully validate the data. Look at the sagittal and coronal views. You can clearly see that sharp dose fall off, those blue and purple zones just perfectly carving out the gonadal avoidance structures. At the same time, the red and green washes show awesome, uniform, whole body coverage for the marrow.
But, a plan is really just a plan until it's actually delivered. So here is the ultimate test, the in vivo dosimetry. Using nanodot sensors placed directly on the patient, the actual measured dose to the testicles was just 0.48 gray. It is just so incredibly satisfying to see real-world measurements perfectly validate a complex plan like this.
Let's also talk about the overall delivery quality. When you compare this to classic linear accelerator TBI, which can have massive dose variations, sometimes up to 50% depending on patient thickness, this is a massive clinical upgrade. We hit homogeneity indices of 1.13 to 1.35. And despite all the complexity, the actual beam on time was highly efficient, clocking in at just 41 to 43 minutes.
At the end of the day, guys, we don't treat phantoms, we treat people. And clinically, this worked perfectly. Both the young male and female patients had successful bone marrow engraftments. They were discharged with uneventful hospital courses, and their follow-ups at 25 months and 3 months were completely unremarkable. Total success. I want to share a quote straight from the technical report that really hits the nail on the head. They state that the ability to reduce the delivered dose to the testes to 0.48 gray will nearly eliminate the risk of long-term azoospermia, and keeping the maximum dose to the ovaries to 1.66 gray will greatly reduce the risk of premature ovarian failure. This right here is exactly why mastering this technique matters. You are literally protecting the long-term quality of life for your young adult patients. So I'm going to leave you with this thought. As you continue through your residency, you're going to see the field shifting from standard total body irradiation toward highly targeted total marrow irradiation. How are you going to use these exact conformal principles? How will you harness advanced tech like tomotherapy to rewrite the standard of care and squash toxicities for your future patients? Think about that as you head into the clinic tomorrow.